It's my pleasure to introduce Dr. Nimjee from Ohio State University. We'll be discussing access to stroke cases. Dr. Nimjee, what are the challenges we're facing today with traditional access?
Dr. Mokin, thank you for having me give this presentation today. When we think about the challenges, it really comes down to owning the anatomy with intracranial access with Zoom 88. And I've got to thank my colleague, Dr. Nimjee from Mount Sinai, who really coined this phrase, and I borrowed it from him. But owning the anatomy is really what we have to deal with in stroke cases. When you and I first started doing stroke, we had these shuttle catheters that could get us into the cervical segment, and then it was really a fight to get your stent retriever up. And clearly successful, right? We have 11 clinical trials to support what we do, and number needed to treat being 3, as we've all been reminded of at this meeting. But what really changed for me is the idea of getting distal access, the idea of getting closer to the clot to have better success in revascularization. And Zoom 88, for me, really represented that first endeavor moving forward to getting closer, to changing my practice from going with a stent retriever first to thinking about aspiration catheters to get the clot out.
Do you have a case for us to show?
So nothing tells the story better than an actual case, right? So classic lesion that we all see. This is a 71-year-old female, presented last known well within 6 hours. She has an NIH stroke scale of 13. As you can probably guess, aphasia with right hemiplegia, and you can see a proximal left M1 occlusion. And in the beginning, on the first of the 3 panels that you can see here, is the Zoom 88 traversing the petrous segment of the internal carotid artery. And at the end of when you see the middle segment, we actually have the Zoom 88 in the M1 segment. So think about, even if you're starting your practice where you want to go with the stent retriever, you now have access to the distal vasculature right where that clot is. And if you're like me, where you transitioned away from doing stent retriever as a first line for thrombectomy, I'm then able to get a Zoom 71 or some other catheter to allow me to ingest the clot, and without having to use a stent retriever, go and do that thrombectomy. And you can see on the last panel, we have a TICI 3 result. And what's even more important about this that I'd like to highlight is not only are you close to the clot, but you get legitimate flow reversal. And what I like to highlight about this is we think about flow reversal in terms of balloon catheters. And as someone who does carotid endarterectomies for a living as well, there's that external carotid artery that can still provide that level of flow into the circulation. But when you have an 088 that's sitting in the middle cerebral artery or sitting in the cavernous segment of the internal carotid artery, you really achieve that full stasis, that full arrest and flow in order to successfully and fully recanalize that vessel.
And there is a little bit of data here. Can you walk us through these numbers, please?
So what do we care about when we're doing a thrombectomy as a neurointerventionalist? We want to get the vessel open with fewer passes. We want it to be quicker. We want a better first pass effect. And finally, you want to achieve that better final perfusion. And in all these elements, you can see that we achieve this with a Zoom 88. And just remembering that a Zoom 88 is a 110 centimeter catheter, that it really allows us distal access in order to get into the intracranial portion of this clot.
And I imagine you'll be talking about it a little bit later, but I keep noticing that you emphasize that 110 centimeter length of the access catheter here. There is also a Zoom support catheter that is getting launched, and you have experience with this.
Yeah, so I think what I saw in the growth of my practice, and look, I've had the chance to use Zoom 88 now for about 3.5 years, and stroke is not all are the same. And what you need in stroke is you need some level of versatility to give depending on the patient that you're treating. And I, along with others, actually provided feedback to say that with Zoom 88, I don't always need 110 centimeters, and sometimes I need a little more support, especially in the case of tandem lesions. These are lesions where having a long 110 centimeter catheter cannot necessarily provide you what you need in both cases. So and I'm not the only person that said this. And what I really appreciated about imperative care is they responded to the physician feedback and really designed Zoom 88 support to respond to the versatility that comes with large vessel occlusion stroke. And the part that was really helpful to me is 3 sections. One, that if you look at the proximal support of the catheter, along with the continuous midshaft transition, and finally the distal segment that has to be flexible for us to get into the intracranial portion, they've shortened it, and you keyed in on this really nicely, they've shortened it from 110 to 100 centimeters. And what this provides me with is a level of versatility and flexibility to address more types of clots. And what I'd like to present to you, Max, to really show that is another case which really talks about one of the things that you and I have to deal with as interventionalists, which is tandem occlusions.
Let's see it.
So this is a patient, a 62-year-old male with a history of hypertension. It's the Ohio special, all right? Hypertension, hyperlipidemia. We got our comorbidities, NIH stroke scale of 10, and I knew from the outset we had a tandem lesion. And as you can see on the angiogram, you can't even see the beginning of the internal portion of the cervical internal carotid artery, and you can see that we have a left M1 occlusion. And this is what was really helpful. I used a Zoom 88 support with a Bernstein selector and just a glide wire. And what I was able to do is still the trackability that I needed, was able to glide the Zoom 88 support straight into the intracranial portion of the left internal carotid artery to provide me with what I needed to ultimately get the intracranial portion taken. You can see in these 2 still pictures, I started with my Bernstein selector, and the way I do it is I track my Zoom 88 support all the way up over the glide wire straight into the intracranial portion. I don't need any subsequent catheters. There's no need to telescope anything, and it gets me right there. And sure enough, you can see that I have my Zoom 88 support in the distal cavernous portion of the internal carotid artery. I'm able to use my Zoom 71 and ultimately realize a TICI-3 revascularization. Now here is where the second aspect of Zoom 88 support is so important, and that is stability. So now I have this portion where that is not going to survive patency if I don't do something about it. So I brought back my Zoom 88 support into the distal part of the common. I kept my glide wire high to maintain access, and then I was able to put a distal protection device and create a 3-stent reconstruction, because you can't appreciate it on this, but I actually had a spiral dissection. And as you know, a spiral dissection is really tough to leave alone because it's guaranteed to close back up again. And I had no movement whatsoever in my Zoom 88 support, sitting nicely in that proximal internal carotid artery, distal common carotid artery, to put a 3-stent construct in, such that when we were finally done, we were able to achieve this level of revascularization in the neck. I had achieved TICI-3 revascularization in the head. So now with a 100 centimeter catheter, with the support that it can provide, along with the distal navigability, I have distal activation, I have proximal stability, ultimately resulting in versatility for someone like this patient who needs that kind of catheter.
This is excellent. And we still have a couple of minutes late. So again, give me a very brief summary. 2 wonderful options. When do you decide to go with a traditional 110 access catheter, and when would you rather go with a shorter 100 Zoom support catheter?
I would say I've had a chance to use almost a dozen of these new Zoom 88 supports now. And if I have a tandem lesion, I'm going to pull Zoom 88 support off the shelf and use that as my first line to do both a thrombectomy distally and then a proximal carotid stent acutely. If I have a distal M1, if I'm going after medium vessel occlusions, I'm going to use a Zoom 88 to get maximal distal access into the M1, the distal M1 that I'll take a Zoom 88 to, and then perform my thrombectomies that way.
Excellent. And I see a very interesting slide reading Zoom RDL. Anything you can share with us?
So Zoom RDL has been another great, I'm glad you mentioned this. What Zoom RDL has allowed me to do is for those cases where I need radial, I go radial and I distal support. And this is not only in the setting of stroke for me, but in all interventions where I want a large bore catheter to allow me the versatility to do the endovascular interventions I need to have. This is a fantastic platform to gain access using the radial artery as your origin and allow the diversity of devices that you'll need distally because you have an 088 at the entryway to the brain.
Thank you so much, Dr. Nimjee.
Always a pleasure, Dr. Mokin.